So now I'd like to introduce you to Baiju. So Dr. Baiju Shah is a health services researcher and clinician-scientist in endocrinology. He's a staff physician and he's also the head of the Division of Endocrinology at Sunnybrook Health Sciences Centre in Toronto, as well as a scientist there. He's a professor in the Department of Medicine and at the Institute of Health Policy, Management Evaluation at the University of Toronto. He's also a senior core scientist at ICES. So he has lots of different roles. Today, he's going to be talking about his research in the area of workplace interventions, but generally, his research seeks to understand and improve the quality of care and long-term outcomes of people with diabetes. And he works in the area of diabetes care in immigrant, Indigenous, and other disadvantaged populations, as well as long-term cardiometabolic consequences for women following gestational diabetes and novel models of healthcare delivery. And finally, of course, as I mentioned at the beginning, he is our inaugural Novo Nordisk Research Chair in Equitable Care of Diabetes and Related Conditions for the Network. And we're so pleased to have you here today, Dr. Shah, to present the work you've been doing in one of the projects you've been doing in the region of Peel. So I'm going to hand it over to you. Thank you very much, and go ahead.
Sorry, I have to unmute myself. So there we go. Okay, thank you so much. Thank you for the introduction, and thank you everybody for joining. So I have presenting today on the topic of health promotion programs in the workplace, and we will have an opportunity for discussion because I think I have left enough time to have a fair amount of discussion at the end. So please feel free to save up your questions for the end. So. I don't have any conflicts of interest related to this work to disclose, but we will talk later about all of the work that we have been doing. So the objectives are really first to really learn about why workplaces are an effective environment for doing health promotion. Why should we even be thinking about this? To review some of the key findings from previous studies about workplace-based health interventions and health promotion activities. And then we'll end off with looking at the real-world impact of a health promotion initiative in a large national employer based in Peel, and that's the work that I've been involved with. So first of all, why should we even think about workplaces as settings for health promotion? Well, I mean, there's a number of important real factors about workplaces that many of us know, but we have to sort of think about them from a practical perspective. Like, most adults will spend about 1/3 of their waking hours in the workplace. And if you only count weekdays, then it's probably more like a half or more than that of your time is spent in your workplace. And therefore, it's just where you are a lot of the time. So if you want to do health promotion or you want to get people involved in health promotion, you got to go where people are, and people are at work. So that's a really important reason why workplaces are a important venue for health promotion activities. And then there's also the facts about workplaces themselves. There's been studies that show that up to 80% of jobs in North America are classified as sort of sedentary or physically light jobs. So, we talk about the importance of maintaining a healthy lifestyle and being physically active. But if your job is making you be sedentary, then that's obviously counterintuitive to or working against you. So the workplace therefore becomes an important place to try and address that deficiency. And actually, the other interesting statistic, which I hadn't even thought about, but up to 60% of people's food intake actually takes place during work hours. So, lunch at work, snacks at work. Many people will have breakfast at work. If you're working late, dinner at work. So a lot of that food takes place in the workplace. And then from the workplace's perspective, we know that stress, mental health problems, musculoskeletal disorders in particular, and cardiometabolic things can also contribute to absenteeism and reduced productivity. So therefore, the workplace itself has a vested interest in improving the health of its employees so that these become less of a barrier to the ability for people to get work done. So why workplaces? So they are actually a strategic setting for health promotion. And from the perspective of the health promotion the health promoters, workplaces provide regular access, repeated schedules, reliably having large populations. And people are always there because they're always at work, so you can always get them. Follow-up is easier, finding them is easier, recruiting them is easier because they're always there. Um, it's also important to recognize you can engage populations that may well be underrepresented in other settings. And of course, in health, we often think about in healthcare settings, and that's where particularly working age people and men in particular may be less well represented and just aren't going to healthcare settings as often. So trying to do a health promotion in those kinds of settings can be challenging. And then, of course, there is an established infrastructure in the workplace. There is offices and common rooms and facilities so that you can do your health promotion activities and have that infrastructure in place to be able to put that together, which may be less available in other community settings. From the perspective of the employee and or the participant in these health promotion activities, the workplace is also a sensible place to do this kind of thing because a lot of those barriers to participation in health promotion are reduced, right? You don't have to worry about getting to and from the appointments. You don't have to worry about childcare. You don't have to worry about taking time off work because you're at work. And so therefore those barriers or excuses for not participating are much less of a concern when the program is happening right at the workplace. And of course, within the workplace, there is that pre-existing social support and peer network that can help sort of positively reinforce behavior change and make that process more facilitated. And then, again, as we talked about already, from the perspective of the employer, there are definite benefits. So there's, from the perspective of employee retention, like this sort of health promotion program, whatever it looks like, could be viewed as a benefit for employees, and therefore it helps maintain people staying in the job or helps with retention. And then it can also reduce absenteeism and presenteeism. So just to define those terms. So absenteeism, I think most people are familiar with, is sort of the phenomenon of people not being able to come to work because they're sick or unwell or injured or whatever. I'd always thought that presenteeism was just sort of the sort of positive framing of absenteeism. So like if you're not absent, you're present. But actually, presenteeism is a bad thing. So presenteeism is defined as people who are going to work despite being injured or ill or sick, and therefore not being able to be as productive or not working as efficiently. And so from the perspective of the employer, again, presenteeism is a bad thing. You don't want people coming to work unwell, not contributing to the extent that the full extent that they can. And if, in the case of an infectious disease, putting other people at risk as well. So both of those, absenteeism and presenteeism, are things that you would want to try and reduce in a workplace setting. So what about previous research on workplace health promotion? So when we first sort of started getting into this, my concern was that there wasn't going to be a whole lot of literature out there. I thought it was going to be kind of a blank screen, that there really wasn't going to be much out there on workplace health promotion activities. That a lot of people are doing this, but it's not probably been actually rigorously studied or evaluated in a sort of in a rigorous way. Turns out I was wrong. So there was this paper that was published just a few months ago in the Lancet Public Health. That's actually a systematic review of meta-analyses. So in other words, there is so much data in this area that there have been so many meta-analyses published that we can now have a systematic review of those meta-analyses. So there is actually an overwhelming amount of data in this area that it actually makes it kind of difficult to distill it into a few slides to present in this kind of a setting to really talk about what the data show, because there really is that much data that's there. Is it actually good quality, rigorous, high quality data? Well, maybe not, but there is a lot of data. So I can get into some of the details of what was in that paper. So they actually found 88 meta-analyses that looked at 339 different effect estimates for interventions delivered in workplaces to improve health. Now, in terms of the clinical areas that were studied, I mean, actually the most common clinical areas were sort of in the stress, mental health, and resilience area. But sort of just below that was cardiometabolic health. So those were interventions or outcomes effects looking at basically at biometric measurements. So weight reduction, blood pressure control, lipid control, type 2 diabetes prevention or management, A1C levels, glucose levels, et cetera. So it's sort of like hard sort of clinical cardiometabolic measures. The health-related behaviors was also fairly common in this literature, and that's sort of one step upstream. So that was looking at behavior. So sedentary behavior or physical activity behavior as the flip side of that, unhealthy diets, alcohol consumption, smoking cessation. So those are sort of another important area. And then musculoskeletal disorders and pain, of course, was very, very important. A lot of these workplace-based studies where that's obviously going to be a primary concern, where, occupational risk for these kinds of things is higher. And then in terms of where these studies were taking place or the kinds of patients that were being studied or employees that were being studied, I mean, the vast majority of cases you can see were sort of not specified. So, it was just looking at literature across workplaces in general. But if you drill down a little further, and some of these meta-analyses did actually look at specific populations, and because there was enough literature out there that looked at specific populations, and unsurprisingly, the healthcare sector was very commonly represented. So you have healthcare workers, you have nurses, first responders, physicians. Like these are sort of fairly common places where we in healthcare will tend to do studies because you're right here in a hospital, might as well just do the study right here. And so there was a lot of literature in that area and those sorts of patients. But there have been meta-analyses also looking at office workers specifically or smokers specifically and so on. But the vast majority of the data has been more broad. And then the types of interventions have been quite variable. This by far the most commonly represented interventions that were studied were sort of counseling interventions, either sort of group counseling or individual one-on-one counseling, focusing on the particular behavior of interest. So whether that is physical activity or dietary change or musculoskeletal pain, cognitive behavioral, cognitive management of that, whatever. These are the sorts of the most common types of interventions that have been studied. There is also research looking at specific environmental change that you can make within the workplace to promote healthy behaviors. So things like standing desks or treadmills to encourage people to be physically active or to at least be less sedentary when they're at work. In workplaces where there is a cafeteria or a food service, there have been a lot of interventions that have looked at interventions within that food area. So either healthy menus or sort of a traffic light labeling system. I mean, we have this here at Sunnybrook, the sort of red, yellow, green labeling on what you should eat and what's healthier for you, what's less healthy. Reducing portion sizes in the cafeteria as well, which is sort of now kind of happening anyway because of costs, but doing it deliberately from a health perspective. And then, of course, smoking cessation activities in the workplace as well. So, and while there are studies that have looked at individual pieces of these, most studies did sort of a more holistic approach and did a multi-component intervention that did different things across different fields. So this is then, again, just to sort of summarize some of the findings from the review of the meta-analyses that found that sort of multi-component interventions are going to be the most efficacious at reducing, at improving health outcomes, unsurprisingly. But the outcomes are relatively modest. So the range in weight loss across these systematic reviews was sort of these meta-analyses was between about 0.5 to 1.2 kilograms. So yes, some weight loss, but it's not gangbusters. Behavioral interventions, so things like pop-ups on your computer screen to remind you to stand up, or organizing walking meetings, or having sort of encouraging physical activity would reduce sedentary time by about 28 minutes per day. And again, not surprisingly, actually changing the environment to promote physical activity, so things like the standing desk, can reduce sedentary time by even more, to 64 minutes a day. And so that was obviously much more dramatic. Interestingly, the dietary-based interventions were able to increase fruit consumption, but there didn't seem to be any change in fiber or fat intake. And maybe that's a reflection of the realities of cafeterias. But that was sort of the finding across the meta-analyses. And then in general, the highest quality evidence, so not based on the sort of grade system, virtually none of the evidence was high quality. Most of it was moderate quality. And that tended to be for weight reduction in sedentary time, and improving glycemic control. So those are sort of the three areas that seem to be the most effective. based on previous research into these kinds of workplace interventions. So just to drill into a couple of the other meta-analyses or that fed into that larger systematic review. This is one that was published also in Lancet Public Health a few years ago. And these are they looked at a lot of different measures. These are the ones that were statistically significant. And again, you can see just generally, first of all, the number of studies that were included in these meta-analyses is actually quite substantial, particularly for the physical measures. But the number of patients or participants total was actually quite small. So if you divide that out, like we're talking 15, 20 participants per trial. So all of these studies or most of these studies were quite small. And the duration that these studies ran was about a year on average. And the pooled effect sizes went in the direction you would hope they would go. But again, the magnitudes were not enormous. So the pooled effect size on fruit and vegetable consumption was, an extra 0.3 servings per day. The reduction in fat as a percentage of your daily energy intake was only about 1%. Weight decreased by about 1 kilogram, BMI reduced by about 0.2, waist circumference was about 1.5 centimeters less, blood pressure went down by about 2/1, and glucose or LDL were reduced by about 0.1 millimole per liter each. So, all statistically significant, all in the right direction, but none of them are particularly dramatic changes. This is another one of those meta-analyses that really focus specifically on physical activity programs. And again, here, this one was perhaps a little bit more impressive in terms of its effects because this was really focused more on physical activity. So they were able to show, this substantial increase in physical activity in terms of steps per day. That's about 7 to 8% more. The VO2 max, which is a sort of a measure of physical activity, was about 10% higher. Fasting glucose was a little bit lower. I mean, obviously, even in the control groups, it was still normal, but it went down in the intervention groups, and BMI also went down. So a little bit more dramatic impacts with these kinds of physical activity measures. So, this is the moral of the story is that there do seem to be these effects across studies of varying degrees of impressiveness, but they are there. I did mention a couple of slides ago that diabetes is one of the areas where there was a relatively good level of evidence. And so given the audience, want to dig into that a little bit more. So of course, the diabetes prevention program probably doesn't need any introduction to many people on the call, but this is a landmark randomized clinical trial that was published almost 25 years ago now, which is making me feel a little old. But basically, they took participants who had both impaired fasting glucose and impaired glucose tolerance. So they're like at the most extreme end of pre-diabetes, just about to tip into diabetes, and randomized them to a placebo intervention, metformin arm, and an intensive lifestyle management arm. We can disregard the metformin for the purposes of this conversation, but really focus on the lifestyle arm. And you saw, so there was a dramatic reduction in weight that was sustained and remained different over many years compared to the placebo group. And the cumulative incidence of diabetes was cut almost in half in that intensive lifestyle arm. So the challenge with the DPP, of course, is that intensive lifestyle arm was really intensive, and it was actually fine to do in the context of a clinical trial to show that it was efficacious and it was plausible and that it had these benefits that were workable. But it was never going to be something that we could actually implement in the real world in clinical care or in other settings to try and prevent diabetes, because it was just not something that was going to be feasible. So in the intervening quarter century since then, there have been numerous attempts to take the DPP program and generalize it into other populations, make the intervention a little bit less intensive so that it would be more scalable, more implementable, more realistic, and make it actually work and demonstrate that you could translate that, maybe not as dramatic a change in weight or diabetes incidence, but still maintain some of those benefits in a larger population in the real world. Numerous studies have done that, but there have been some specifically that have been looking at workplaces. And in fact, there is even this position statement from Diabetes Canada on the importance of workplaces in Canada to reduce the risk of type 2 diabetes through workplace programs. And this was a bit of a surprise to me. I didn't know this existed. There aren't any authors on this paper, interestingly enough, so we don't actually know who wrote it. There was a little webinar that was published at the same time, which has some familiar faces on it. So perhaps they might have some insight into how this position statement came into being. But basically, what the position statement says is there is a mandate for Canadian workplaces to be able to do this to promote the health of their employees and reduce the risk of diabetes across the population. What they found in some of the analyses that they performed in that statement is, again, unsurprisingly, diabetes prevention programs that were based on the DPP study. So in other words, based on that randomized controlled trial and those sort of rigorous methods that were used there, were more effective at weight loss than diabetes prevention programs that weren't grounded in that trial basis and were just kind of a program that somebody put together. That's probably not surprising. I'm going to show you a couple of the trials that have been done looking at diabetes prevention programs in workplaces, just to sort of highlight some of these interesting findings. So this is one that was done at an American university. So it was looking at 78 employees with either with prediabetes and an increased BMI. And they randomized them to either this intervention arm, which was a 16-week group-based intervention that was adapted from the DPP. They met in groups of sort of 10 to 15 people over lunch hour or after work for 1 hour a week. And they had lifestyle coaches at those meetings who were registered dietitians. And they set these sorts of goals, which are the goals that are kind of derived from the original DPP, a weight loss goal, a physical activity goal, and a dietary goal. And the control group was just kind of usual care, continue doing what you're doing, no specific intervention, no group counseling. And the findings were actually quite interesting. So if you focus on the outcomes on the left there, so they looked at weight, waist circumference, glucose, and diastolic and systolic blood pressure. I just put one of them on the slide. You can see the intervention arm in blue versus the control arm in green had dramatic improvements at the end of the intervention for all of these outcomes. But what was even more interesting was that the intervention was only 16 weeks long. They tested everybody again at the end of those 16 weeks, but then they went back 3 months later and tested everybody once more, 3 months after the intervention had ended. And most of these benefits were sustained. So the weight loss continued for the intervention group. The waist circumference continued. In fact, it got slightly better. Blood pressure remained as good and glucose remained as good in the intervention group. The control group, actually, interestingly, for glucose actually got better over time. Not sure what drove that, but the differences between the groups remained for everything except glucose at the 7-month mark. So that was an interesting finding that these are actually sustainable changes, not just during the life course of the program. And then one other RCT to talk about. This was one that was actually done at Bayer. So again, kind of a healthcare adjacent setting. I mean, they're not healthcare providers, but they are in the healthcare world. And this was a step wedge design of 89 employees, again, with prediabetes and a BMI over 24 here. So the idea of a step wedge is that rather than saying some people get the intervention and some people don't, with a step wedge, everybody gets the intervention, but what changes is when they get it. So here, 2/3 of the people got the intervention right at the beginning. 1/3 of the people got it after 6 months. So for those first 6 months, that second group could act as a control for the first group. And then eventually, of course, everybody did get the program because this was an employer and they didn't want to provide this for all of their employees in the end. Again, they adapted the intervention from the DPP. It was based on these sort of face-to-face group meetings at the workplace once a week for the 3 months. Or interestingly, they also offered people, you have the choice of either doing the face-to-face or getting a DVD version of the counseling session, which is a little retro now, but I mean, that's how they did it back in the day. And individuals had the choice of which they wanted, whether they want to do the face-to-face meeting at the workplace or just do it on the DVD. The majority actually did choose the face-to-face, but there was a substantial proportion who went for the DVD version. And then at the end of that 3 months, it reverted to the sort of biweekly and then monthly follow-up meetings going all the way out to the year. The goals, again, as with the previous study, are the sort of the DPP goals in terms of weight loss and physical activity. And here are the 6-month results. So I'm not going to show you the 12-month results, but at the 6-month results, so the intervention group had been in the program for 6 months. The control group was just about to start it, but they had been controls for those 6 months. The stars indicate where there was a change from baseline within the group. So the people who were in the intervention had a 10-pound weight loss from baseline versus only a 2-pound weight loss in the control group. And that was, of course, very statistically significant. They also had a reduction in their waist circumference from baseline, which the intervention group didn't, statistically significant. Their A1C went down by 0.1, so not a huge change, but it was a statistically significant change and statistically significant from the no change in the control group. Again, these are people who didn't necessarily have diabetes, right? They had pre-diabetes, but we did have a reduction in their A1C. The blood pressure, neither group had a within group difference, but the intervention group tended to go downwards. The control group tended to go upwards. So as a result, at the end of the 6 months, there was a difference between the two groups that was statistically significant. And on the physical activity side, actually, both groups had an increase from their baseline. So there was no difference between intervention and control at the end of the 6 months, but they were both better than baseline. So that's just sort of a quick overview, just a light skimming of the really extensive literature that's out there on these kinds of workplace interventions. But now I want to spend the rest of the time really talking about the intervention that we've been working on and that we've been studying. So this is a real-world example of workplace health promotion right here in Peel Region. And so this is a project that has been sort of led and run by Purolator, in collaboration with Cleveland Clinic Canada and us at the University of Toronto. So, Purolator. Most of you probably know what Purolator is. It's a large Canadian courier and logistics company. Their national headquarters are in Mississauga. They specialize in express delivery of parcels and freight and supply chains and so on. As a company, they've got more than 150 different facilities across the country and more than 14,000 employees. Purolator Health is a program within the company that's there to support workforce health, and it is run by Dr. Sean Chung, who has joined us on the call. He's an internist at Trillium, but also he moonlights as the medical director of Purolator Health. So, and he can correct me if I misspeak anything here, Sean, please do. So Purolator Health really, there was a major focus on mental health of the employees during the pandemic, which is obviously important and was critical in many different workplaces. And then post-pandemic, they've sort of spread out and moving in beyond just mental health and now looking also into physical health among their employees. They developed this health promotion initiative in collaboration with Cleveland Clinic Canada, and I'll show you in a second what that looks like. But basically, Cleveland Clinic is tied to the Cleveland Clinic in the U.S., of course, but they have Canadian branches, including one in Toronto, where they are able to do some sort of traditional healthcare delivery, but also they have a whole area working with executive health and employee health and workplace health and that kind of thing. And they have these programs that you can work with them for and sort of plug it in a particular place or a particular environment. And so they Purolator worked with them to kind of create this health promotion initiative for the employees of Purolator. And this program was pilot tested at 3 sites for Purolator in 2024. So just to show you what that intervention looked like at each of the 3 sites, there was sort of prior to the main kind of day, there was a marketing and awareness building campaign to let the employees know that this was coming. This was something that was going to be available for you. You can participate in this. There were local champions at each site who sort of talked it up and encouraged people to get involved and get people to participate. There was advertising and sort of posters and videos and stuff to let people know this was coming, as well as kind of pre-circulating what was going to be there so you would know what to expect when you rolled in for the clinic. And then the clinic day itself had people from Cleveland Clinic show up at the site, the Purolator site, and employees were able to pre-book a time slot, and then there was also spaces available for walk-ins to come in and go through the process. So basically there was a consent to participate in this process. All the participants completed a questionnaire that included a variety of questions. So there was sort of basic demographic information, there was medical history questions, there was behavioral questions in terms of physical activity, dietary behaviors, and smoking and that kind of thing. Um, then they also underwent a biometric screening. So there was a blood pressure taken, weight, uh, BMI was calculated, and then they had blood tests taken for A1C and lipids and so on. And then there was, at the end of that, there was a kind of report generated for the employee that showed them, these are your parameters, this is what your health risks are. Let's highlight these are particular things that you need to be aware of. Oh, look, your blood pressure was a little high. Oh, look, you're smoking, whatever it is on the questionnaire that came up as a potential health risk. For people who didn't have access to primary care, there was some help provided with navigation of the healthcare system. And then everybody, I mean, obviously focused on those who had abnormalities identified at the baseline visit, but everybody was offered this sort of ongoing care, which were these virtual health coaching intervention visits with a nurse practitioner from Cleveland Clinic. So this was done virtually, so it didn't have to interrupt work or being able to have to go to the site in downtown Toronto to receive this care, but it was targeted around whatever was highlighted from that baseline visit. So if a person's, was had their BMI was elevated, then the virtual health coaching was really going to be focused around weight loss and so on. Everybody was offered this, a proportion of people attended the first visit, and then obviously there was drop off as time went on in terms of how many people actually had regular visits all the way through the 1 year of the program. And then at the end of the 1 year in 2025, Cleveland Clinic went back to the workplace again, invited all the people who had gone through the first time to come back, repeat the questionnaire, repeat the biometric screening to be able to see what was changed. And at that point, they provided them with a consent that we had generated in working with them and working with the team over the year of 2024, 2025 to have the participants consent to data sharing for research purposes. So since this is a lot of people in this group are interested in data, just a little slide about how the data sharing works. So there was an existing service agreement between Cleveland Clinic and Purolator before we even got involved for doing this whole biometric program. And that included the opportunity for Cleveland to share the data, the de-identified patient data with Purolator. Purolator didn't actually want the de-identified patient data, but it was their part of the agreement. But that allowed then us to have a data sharing agreement with Purolator to be able to receive that de-identified data for us for research purposes. So quite literally, we got on a Zoom call and Cleveland sent the data to Purolator, who then turned around and sent it to us and deleted it. So Purolator was in possession of the data for about 3 minutes, and it kind of flowed from Cleveland to us in that way. And then we were able to take that de-identified data and do some of the analyses that I'm going to show you. So as I mentioned, there were 3 sites in this initial pilot project, so 2 in the GTA and 1 in Richmond, BC. There were 355 employees across those 3 sites who participated in the pilot program in May and June of 2024. And then we had 137 who returned in 2025 and consented for that research data sharing agreement. And so we were able to get the data on those 137 people who consented to that research process. Now that's a bit of a drop off. Obviously, we weren't able to get the information on all of those other people who went to the baseline but didn't come back for the follow-up. We do know that virtually everybody who came for the follow-up did consent to the data sharing for sharing the data with us at U of T. I think there was only you could count on one hand, I think, the number of people who actually came back to the follow-up but refused the data sharing. So the drop-off was really just people who didn't come back for the follow-up. And we don't really know why that is. It may be that people were just, no longer with the company. They moved on to a different job or they were at a different site. Possibly people had, they'd done it once, had really good results and didn't want to bother coming back. Or conversely, had really terrible results and didn't want to know again. So we don't really know what's the characteristics of those who were missing. But in those we have, this is sort of the demographic breakdown that we see and sort of what you would probably expect at a workplace site like Purolator. The age range, more men than women. Interestingly, though, considering mostly male and this kind of age range, the vast majority of them actually did have a primary care provider, and only a minority didn't have a primary care provider. We didn't actually ask them when they saw their primary care provider, but people did have one, which is, this proportion is probably better than the Mississauga general population, right? So this is actually surprisingly good, and maybe that's a reflection of this 137 from the 355, like we're catching the more engaged people who are actually coming back. So we, as I mentioned, asked all of these participants at Purolator, what is your health history? And then we did the biometric measures. And so interestingly, across the two visits in 2024 and 2025, among people who said they did not have a history of hypertension, we had 34 whose blood pressures were above 140/90. So, hypertension based on a one reading in a non-ideal circumstance. So one reading is perhaps not the best, but it's, we are using 140/90 as the threshold. And then among people who did not report a history of diabetes, we had 17 whose HbA1c was between 6 and 6.4, and another 5 who were at 6.5 or higher. So that's, out of 137 people, these are pretty significant numbers of people who have undiagnosed diabetes, prediabetes, and potentially undiagnosed hypertension as well. So that's really striking, and probably one of the major kind of takeaways from this is that we were finding a large number of people with these conditions. We were then able to look at, among those 137 people who did go from the baseline to the follow-up, what was the change in their measures over that time. And we did see a statistically significant improvement in the systolic blood pressure over time. The diastolic didn't change, unfortunately. The LDL got slightly better. Unfortunately, the weight, BMI, and the A1C got slightly worse, and again, statistically significant, although numerically these numbers are quite small. But if we focus on really, this is on everybody. And so a lot of the people who had, let's say a normal A1C or a normal weight, we wouldn't necessarily expect them to improve after a year of potential of exposure to virtual health counseling and so on. Among those who were above target at baseline, so whose blood pressures was over 140, we had diastolic was over 90, A1C was over 6, and the LDL was over 3.3. We did actually see much more dramatic improvements in their parameters over the course of that 1 year. So that's, at least in those who were already abnormal, we were able to demonstrate there was a benefit. In terms of the behavior stuff, none of these were statistically significant, but I just wanted to share this with you. So we did show, no change in smoking rate, slight reduction in alcohol use, slight improvement in healthy eating, and, marginal change in regular exercise. So that's kind of that study and what we were able to accomplish in that pilot phase, 2024 to 2025. But we were continuing to move forward, and we were moving forward and trying to make it more methodologically rigorous and more impactful as we go forward. So phase 1 was that sort of retrospective cohort study that I've just finished describing for you. Phase 2, which we're starting now, 2026 to 2027, is going to be a prospective cohort study. So we are actually going to go in at the first visit and get people's consent to participate in the research. So we will not have that big drop off in people who we lose over time, and we'll be able to get everybody at the beginning and see, get that consent. And people may decline to consent, of course, but based on our previous experience, we don't think that's going to be very strong. So there's 3 sites that are going to be doing this year, and then we'll have their follow-up next year, and we'll be able to see, if the results in the bigger cohort of people prospectively collected give us more different results or similar results to the retrospective data. And then finally, we are working towards building a randomized controlled trial, and that's going to be in whenever we get it designed and built and, most importantly, funded. But what we really want to do is take what we learned from that previous literature that I started with, customize it to the needs of Purolator, customize it to what's feasible by Cleveland Clinic in this kind of structure that we have, and maybe make some tweaks to that structure to make it a little more evidence-based, and then do a randomized trial at additional Purolator sites. Remember, we've got 150 odd ones to choose from, and we've only used 6 so far at the end of phase 2. To see what we can do to further improve the health of employees at Purolator, and then use that information in what will hopefully be a much larger trial than most of that previous literature that I was showing you, to be able to demonstrate benefits of workplace health interventions. So just want to end finally by thanking the people who've been involved in this work. Of course, the leadership and folks at Purolator and Cleveland Clinic who've been really helpful. At Purolator specifically, Sean, who I've already mentioned, and Ashley, who's joined us on the call as well, have been really instrumental in leading this work at Purolator, championing it, working with their employees and with their leadership to get this rolling and to really build in this research lens, which I think is really important. A lot of people, a lot of places do stuff without really wanting to know or without even thinking about the importance of evaluation. So 100% credit to Sean and Ashley for really helping us support us in building this in from the beginning. And of course, Ipsita, who you all know, who my research coordinator and who's been doing all of this work and crunching all of these numbers for us. So with that, I will wrap up, and we have some time left over for questions.
Thank you so much, Baiju, for a really excellent presentation, a nice review of the literature, and then bringing it to sort of what you and your team have been able to do locally. So really excellent. Thank you for presenting that. I'm going to open it up. Does anyone have any questions or comments? Just going to see. Please raise your hand. Oh, there's Shushmita. Oh, great. So Shushmita from Diabetes Canada, thanks for joining. I'll read out her question. So thanks for the informative presentation. Beyond tracking health outcomes, did any of the workplace interventions that were reviewed track changes in organizational level performance indicators such as presenteeism, absenteeism, employee engagement, and satisfaction? And could capturing these data get more organizations to adopt these types of interventions? Great question.
Yeah, that's a great question. So these systematic reviews that I looked at were really focused on the health outcomes. So I did not drill into that question about whether that's there or not, but I think that's critical. And I think part of the job of selling this to employers to invest in this will be on those facts. We talked a little bit with Purolator about whether we would have that opportunity to get into some of that data. We'll see whether or not that's feasible. I think there are still, obviously understandable concerns about making sure the research and the stay separate from the HR and the employee stuff and the legal and the privacy. It's like I get why that needs to be firewalled very strictly, but I think it would be important, I think, to go back to the literature and maybe even do a literature review looking at those metrics specifically.
No, thanks, Baiju. And one of the things the team could consider is even just looking at a kind of ecological sort of analysis. Yeah. Have these concerns improved since this was implemented? Forget about like who participated and who didn't, but just in general. Yeah, right.
Exactly. Like just generally, is there less absenteeism at that site versus other sites? Right. Absolutely.
Yeah, to get around the whole confidentiality issue.
Yeah.
Yeah, no, great. You've got a lot of people saying great presentation. I'm just going to open it up if anybody else has any questions. While we're waiting, maybe I can ask one, Baiju. So you kind of went through the intervention. A lot of it, of course, was around giving people an opportunity to have a biometric evaluation and to get some education around, cardiometabolic health. However, you also had that health coaching component. Now, maybe I missed it, but can you tell us a little bit more about what that looked like, especially because you gave some of the background on the diabetes prevention program and how workplaces that adopted that specific model had better outcomes than those who just kind of did other things.
Yeah.
So how did this get rolled out? Like who got?
Yeah. So this was not. Yeah, this was not a diabetes prevention focused outcome. So it wasn't a DPP kind of based intervention. So we were definitely in that other group of non-DPP kind of kind of structures. I mean, basically, it was the same NP actually who had been the one at the screening event would be the one who would do that sort of longitudinal follow-up. So there was that continuity of care, which was, I think, an important piece to it. And it was offered to everybody, particularly those who had abnormalities at baseline, but offered to everyone with varying degrees of uptake. There was a 1 month follow-up and then I think then a 3 month and there was like sort of at regular touch points. There wasn't a formal structured curriculum, and that's one of the things that we are looking to change as we sort of build this towards a randomized trial to make it a little more formalized about what actually happens in that 1 year of longitudinal follow-up. Like what are we actually going to do? Because I think it was kind of whatever the person wanted to talk about was kind of what the NP would talk about with them. So there wasn't a kind of formal program or curriculum or anything like that. So it was a little loose in that sense. But it was also, I think, the accountability was there, right? Because you still,
Yeah.
even if it wasn't clear what you were talking about, you had to go talk to some. It was you were talking to a healthcare professional on a regular basis about whatever it was that you had abnormal at the beginning, and so it was important to sort of that as a motivator to get people going and to get people working on behavior change, or even thinking about behavior change and connecting with their primary care physician, and all of the other things that are needed.
Yeah, no, that's great. And the accountability is really huge in health coaching and behavior change. Just a plug, I mean, I don't know what kind of background the nurse practitioner has in health coaching, but there is a certified health coaching program now being offered at McMaster, ran by our friends Diana Sharafali and Lee Kaplan. And it's for healthcare professionals specifically, and it gives them core skills in health coaching, and it's general, not just cardiometabolic health. They touch on that, but then they touch on a lot of different things. So could be something to consider, obviously, if there is a need for more formal training. But the
Yeah,
curriculum, I
absolutely.
think, would be an interesting idea. And even the talk about the discussion about getting that consent at the beginning, I think is good. Yeah.
Yeah. And I mean, maybe we can even like get consent to data linkage and bring the data to ICS so we don't even need to worry about the follow-up, right? Like there's lots of opportunities and things
Yeah.
to think about.
Yeah, yeah, for sure. And what happened to people who screened positive, in terms of course, you mentioned they were given their results, they were given the opportunity for health coaching, but what if they didn't have a family doctor, or even if they did, like how did that loop get closed? Like,
Yeah, so that was part of the like at that baseline visit. And most of them actually did have primary care physicians, so it was less of a concern. But those who didn't were, supported with navigating to a healthcare provider in the vicinity by the Cleveland Clinic staff. And if nothing was working out, then they were actually, able to get that through Cleveland as a kind of a stopgap until something more formal was put into place.
so that even in of itself is a good intervention, right? Just navigating,
Yeah.
providing with resources. Any other questions? Just looking, you've got lots of great comments. Just wondering if anyone has any more questions. We have a few minutes in case somebody has something to say. I don't want to put Sean on the spot. Are you still here, Sean?
Hey,
Because I know
yes.
you've been partnering with Beiju on this since the
Yeah,
beginning.
yeah.
So love to hear your comments if you have any.
No, I just like Beiju has pretty much covered it all. And I gotta say, like Beiju, this is an excellent, excellent talk. And just so proud of this partnership and everything that we've done here. I mean, the big picture here from a company perspective, just putting on my Purelator hat now, is how do we really make our employees give them the best quality of health given how strained our healthcare system is right now? And the fact that you're working at Purelator, you're getting this level of care. So from the question that was raised earlier about absenteeism, presenteeism, those are the metrics that we think about on the company side of things, as opposed to when I put my university hat on and my doctor hat, we're thinking more about, HbA1c, blood pressure. But this program really has moved the dial in a positive direction on those other metrics, and just really, really proud of this work and the partnership. So thank you, Beju. And thank you, Ash. I think Ashley's here. Such amazing work. Thank you.
Yes, thank you, Ashley. I remember those early discussions when she was there. So great. And thanks, Sean, for your leadership, both of you, Beju and Sean, for your leadership on this project. I think it's really worthwhile. As you saw, along with my colleague, Diana Sherifelli, we did give a talk about workplace interventions. It's something that I feel is very important, as I think we all do, and we're all recognizing the opportunity. So thanks for articulating that really well, Beju. Any other
Did you
questions?
write that position statement, or do you know who did write that
No, I
position
did
statement?
not. I don't know who wrote it. It was,
Okay.
I know that the folks at Diabetes Canada are very aware and familiar with it and use it, but I actually I think it was put together by a team prior to the current team. So yeah, I'm not sure, but it's a
Very
good
anonymous. It's
position
interesting.
statement. Pardon?
It's entirely anonymous. It's
Yeah.
interesting.
Yeah, yeah. Any other questions from the audience? Okay. Well, if we don't have any other questions, I just want to ask everyone to join me in thanking Beju for an excellent presentation, for a really great discussion, and we really appreciate all the work you're doing, and we're really looking forward to hearing next steps. We really hope that you get some funding to do an RCT. I think this would be really, really great. And we can learn from what you're doing and potentially look at opportunities in other workplaces. So thanks everybody for joining. Please ensure you complete today's evaluation for the session. It's really important to us that we have completed evaluations to maintain our continuing medical education or CME accreditation standards. So thank you so much for your efforts in doing that. It also helps us to get feedback on the types of talks that we're presenting and offering, and where we can best meet your needs. So as for our next May session, we're going to be having a bit of a different session. We're not going to be having our usual virtual Monday session, but instead we are hosting a really special visiting speaker who's coming from the UK on Wednesday, May 6th. Dr. Jonathan Valabji. He is a professor and diabetologist from England, who is the head of the NHS diabetes prevention and remission programs there. And he's going to be speaking on the experience in the UK on widespread population-based diabetes prevention program, as well as a diabetes remission program. He will be speaking in person at Women's College Hospital. He'll also be speaking, we'll also have a virtual option available. So please make every effort to register. We'd really love if you could join us. And we're really excited to hear about what they're doing there and how we can potentially learn and implement some of those strategies here. So thanks so much, everyone, for joining. I think we have a few extra minutes, but either I give them back to you or anyone else have any last minute questions or comments. Otherwise, thanks, everyone. Take care.